right, so my name is Nicole Smith. I'm in the maternal fetal medicine practice at Brigham and Women's Hospital, and I'm going to be talking about obstetrics for the general surgeon. I have no disclosures. I'll start by reviewing the physiology of pregnancy, then move on to discussing some of the most common disorders of pregnancy, as well as how we do the postnatal counseling for hypertensive disorders, diabetes, and a few maternal hematologic disorders, and then move to the general guidelines for surgery in pregnancy and a couple of common surgical conditions that we see in pregnancy, with hopefully answering some of the most common questions that we receive from surgeons in this area. So we'll start by reviewing pregnancy physiology. The cardiovascular system is one with some of the most changes that we see with pregnancy. There is a very early decrease in blood pressure, which is mediated by progesterone, which causes a drop in systemic vascular resistance throughout the body. As pregnancy progresses, though, the increased blood volume mitigates that decrease in systemic vascular resistance to bring blood pressure back up. There is some increase in heart rate as well, very early, as early as the 7th week of pregnancy. The fluid expansion is due to sodium and water retention. Plasma volume increases by a total of approximately 50% during pregnancy. And that increase is seen, again, as early as the first trimester, with a more rapid slope of the curve of increase in plasma volume between approximately 20 and 24 weeks gestation, and a somewhat leveling off around 30 or 32 weeks, although plasma volume does continue to expand up until the end of pregnancy. So summarizing some of the cardiovascular changes, there's a slight increase in heart rate, only about 10 to 20 beats per minute. So keep in mind that tachycardia in pregnancy is abnormal until proven otherwise, just as it is outside of pregnancy. There is a 30 to 50% increase in cardiac output, which is largely mediated by increased stroke volume through plasma volume expansion, but a 20% decrease in systemic vascular resistance. Some of the hemodilution that we see during pregnancy from the plasma volume expansion is thought to protect women from the blood loss that occurs at the time of delivery. So a healthy pregnant woman can actually lose up to 30% of her blood volume with little to no changes in her hemodynamic status, with average blood loss from a vaginal birth being about 300 cc's, and with a C-section, about 1 liter, 1,000 cc's. Postpartum, women usually start to diurese between 2 to 5 days postpartum, losing several pounds fairly rapidly just from losing the extra plasma volume. Some women, those, for example, with preeclampsia or with some underlying vascular disease, find it much more difficult to get rid of that extra fluid, which can lead to higher intravascular volume than extravascular volume, with an increased risk for pulmonary edema. Pulmonary symptoms are troublesome for many women in pregnancy. Dyspnea is very, very common. Up to 3/4 of women experience dyspnea either early on or in the later parts of pregnancy. However, acute onset of shortness of breath deserves a careful evaluation and needs to be considered pathologic until proven to be physiologic. In the minority of cases, cardiovascular disease can actually be the etiology of this acute decompensation. Peripartum cardiomyopathy is rare, but it's life-threatening and should always be in the differential, particularly in the 3rd trimester of pregnancy or the postpartum period. It's worthwhile mentioning that women with underlying valvular disease may poorly tolerate plasma volume expansion. So while some women are aware that they have underlying valvular disease, many women aren't aware that they carry this diagnosis, and they can get quite sick, typically at the onset of the 3rd trimester, again, due to that rapid plasma volume expansion that I mentioned. There are some mechanical changes associated with pregnancy. The diaphragm elevates by about 5 centimeters, with a thoracic circumference increase by about 8%. This is, of course, later on in pregnancy in the 3rd trimester when the growing uterus is pressing up against the diaphragm. Overall, there's an increase in tidal volume by about 40%, with a decrease in the expiratory reserve volume. There's also a decrease in functional residual capacity due to some of those mechanical changes that I described. Moving to the kidneys, just as plasma volume expands, renal plasma flow and glomerular filtration both increase as well. They increase early, and they increase to about 50% over the course of pregnancy. There's a subsequent decrease in average serum creatinine with an upper limit of normal of approximately 0.8. It's important to remember that if you see a creatinine of 1, it's never considered normal in pregnancy. You may see it as a relatively normal value in someone with underlying kidney disease, but outside of underlying known renal insufficiency, a creatinine of 1 should always be considered pathologic. While pregnancy doesn't alter daily urine output, urine protein excretion may slightly increase in the second half of pregnancy as compared to the first half of pregnancy. The 95th percentile for 24-hour urine protein excretion is about 260 milligrams, which is where we get the threshold of 300 milligrams per day, which is classically described in the diagnosis of preeclampsia. There are very few changes in the gastrointestinal tract which have much clinical significance, but it is quite troubling for women and can cause some of the most distressing symptoms of pregnancy. Progesterone decreases lower esophageal sphincter tone, causing an increase in reflux and heartburn. It also causes a slowed gastric motility with some pretty significant constipation. It's important to remember that the placenta produces alkaline phosphatase, so AlkPhos levels will naturally be elevated during pregnancy and don't indicate hepatic obstruction. Increased gallbladder stasis may increase the risk of stone formation. The liver function tests of the aminotransferases, coagulation times, also bilirubins should remain normal in pregnancy, and any abnormal value should be considered, again, pathologic until proven otherwise. There are some important changes in typical hematologic parameters. Hemoglobin on average decreases over the course of pregnancy, with normal values described as over 10.5. This is largely due to an iron deficiency anemia, though plasma volume expansion also contributes to a physiologic anemia, which would be seen with a decrease in hematocrit over the course of pregnancy. Interestingly, pregnant women frequently have an increase in their white blood cell count, which is normal. A typical value would be 14 or under, although we do rarely see even higher normal white blood cell counts. Typically, these white blood cell counts shouldn't really be above 16 to 18, and a normal white blood cell count should, of course, have a normal differential. So a white blood cell count with a left shift should again be considered pathologic. Platelet counts remain within the range of normal for outside of pregnancy, or in other words, greater than 150,000. There are a lot of changes in the coagulation cascade. There's an increase in fibrinogen, a decrease in protein S and protein C, and an increase in factors 2, 7, 8, and 10. So let's move on then to some of the most common pregnancy disorders that you may very well see in some of your patients, and postnatal counseling. The hypertensive disorders impact about 15% of all pregnant women, and there's quite a large family of them, from chronic hypertension to the preeclamptic disorders of preeclampsia, superimposed preeclampsia, eclampsia, HELLP syndrome, and then gestational hypertension, or in other words, hypertension of pregnancy. It can be pretty confusing to differentiate between these and make a clear diagnosis, but I'll try to describe some of the basic tenets of diagnosis. This is a very classic presentation of preeclampsia. So CM is a 32-year-old in her first pregnancy. When she initiated prenatal care, she had a very normal blood pressure, no proteinuria. Everything went along smoothly until she appeared at 36 weeks with edema of her hands and face. She had a rapid weight gain. She had very high blood pressure and some significant proteinuria. What's interesting is that this is actually a case report from the records of the Boston Lying-In Hospital from 1862. And it just, goes to support the fact that while times have changed and medical treatment has changed, the diseases around pregnancy really haven't. Preeclampsia is a disease of the placenta, and it's cured by delivery. The term preeclampsia was coined in the 1800s by Dr. Lever. And if you trained more than about 5 years ago, you probably are familiar with the terminology of mild preeclampsia and severe preeclampsia. Some new guidelines came out in 2013, which changed that terminology. So now what we talk about is preeclampsia with and without severe features. And perhaps the reason for that is that there may have been an overemphasis on the importance of protein excretion in terms of predicting adverse outcomes in pregnancy. So the current state of diagnosis of preeclampsia with severe features is fairly similar to what it had been prior to 5 years ago. So in other words, an elevated systolic blood pressure over 160, diastolic blood pressure over 110, elevated creatinine showing evidence of renal impact or evidence of other end organ dysfunction. So a doubling of liver function tests, a drop in the platelets, or neurologic changes. Preeclampsia without severe features is a little trickier. Still, the hallmark is hypertension. And while proteinuria is helpful in making that diagnosis, it's no longer essential for the diagnosis of preeclampsia. Who is at risk for preeclampsia? Well, pretty much any condition increases the risk of preeclampsia. So nullips, or in other words, women having their first baby, have an increased risk of preeclampsia. If women had preeclampsia in their past pregnancies or have a first-degree family member, those women over 35, and certainly with an increasing risk as women become older in pregnancy. Many, many medical conditions, including chronic hypertension, maternal obesity, pregestational diabetes, lupus or antiphospholipid syndrome, chronic kidney disease, and many others. Multiple gestations increase the risk of preeclampsia as well. The risks of preeclampsia are shared by women and their babies. The risks to babies include prematurity due to indicated preterm delivery, growth restriction, placental abruption, and stillbirth. Maternal risks include stroke, seizure, liver rupture, and an increased lifelong risk of cardiovascular disease. The goals of management in preeclampsia are really healthy mom, healthy baby, or healthy babies. Most women at presentation have no permanent deficits. It's much easier to counsel women when they're at term than when they're preterm. So gestational age is critical as we're making management decisions. There are a lot of antihypertensives that we can use quite safely in pregnancy. These are 3 of the most common, hydralazine, labetalol, and nifedipine, but there's a long list of other medications that can be used quite safely in pregnancy as well. Seizures are an unfortunate complication associated with preeclampsia. Seizures in pregnancy were actually first described about 3,000 years ago by the Egyptians, and Hippocrates described them in about 400 BC as well. The term eclampsia was first coined by this gentleman here in the 1700s. This is a Greek word which means lightning. And essentially eclampsia, as you can imagine, it's like a lightning strike during pregnancy. It's the development of generalized tonic-clonic seizures in a pregnant patient who does not have a seizure disorder. Eclampsia is not common. It's seen really in just about 1 in 2,000 to 3,500 pregnancies. The biggest risk factor is preeclampsia. Eclampsia is frequently seen with symptoms such as headache or other neurologic changes like visual changes, blurry vision, photophobia, but not all women describe symptoms prior to the seizure. So it can be very, very difficult to predict, and we worry about all women with preeclampsia with severe features and their risk of developing eclampsia. 1/3 to 1/2 of women have eclamptic seizures prior to delivery. There's an uptick during labor, And then the remainder of cases happen within the first days to weeks postpartum. A patient who presents with seizures more than a few weeks out from her delivery really needs to be evaluated for another etiology of seizures. There have been many studies looking at best management for women with preeclampsia and eclampsia, and the best treatment based on randomized controlled trials for the development of eclamptic seizures is magnesium sulfate infusion. And that's been demonstrated to reduce the risk of recurrent seizures as well as reducing the risk of maternal death. The next category in this family of hypertensive disorders is chronic hypertension. So chronic hypertension is diagnosed as hypertension prior to pregnancy, but not all of our patients are getting routine healthcare outside of pregnancy. So for us, we have a secondary diagnosis of chronic hypertension, which is hypertension prior to 20 weeks gestation. There's a third category as well, which is hypertension, which is first seen after 20 weeks, but persisting more than 12 weeks postpartum. That's, of course, a retrospective diagnosis, so can't be made during pregnancy. Our goal with chronic hypertension is to optimize medication, to optimize blood pressures. Now, gestational hypertension is a little bit difficult to diagnose. It's sort of like a you know it when you see it, but it's still confusing to differentiate these days between gestational hypertension and preeclampsia, now that the diagnosis of preeclampsia no longer requires an increase in protein excretion. Gestational hypertension, just like preeclampsia, can be associated with adverse outcomes. And again, as I mentioned, 10% of eclamptic sees without proteinuria. The risks associated with either gestational hypertension or chronic hypertension are really related to the severity of the hypertension itself. And based on the severity of the underlying disease, you are better able to predict the likelihood of either superimposed preeclampsia, intrauterine growth restriction or IUGR, placental abruption, and delivery prior to 37 weeks, which is the onset of term. Basic guidelines for management are optimizing blood pressure control. We use a lot of blood pressure medicines. Methyl-dopa is the oldest, one that people are the most familiar with. It has an excellent side effect profile. It's also not effective for many, many patients. And our mainstays of treatment these days tend to be labetalol and nifedipine. There are other agents that can be used as well. We can use diuretics, we can use beta blockers. We just need to use them with a little bit of caution and with perhaps some increased fetal surveillance. The goal in general is a blood pressure of under 150 or 100. However, that tends to be what we're aiming for when hypertension is diagnosed later in the pregnancy. For women who come in the first trimester with a diagnosis of preeclampsia, we may aim to keep their blood pressures a little bit lower, as pregnancy is really quite long, and having hypertension for the better part of a year is not beneficial to women's overall health. In terms of delivery timing, for women who have some hypertension but they're not on any medication, we deliver them on the later part of term. And for women with well-controlled hypertension on medication, we deliver them sometimes on the earlier side of term, down at 37 weeks. There's a lot of gray zone here, so if it seems confusing, it's because it is to obstetricians as well. What about superimposed preeclampsia? Well, superimposed preeclampsia has classically been described as new onset proteinuria in a patient with chronic hypertension after 20 weeks. However, of course, again, we don't necessarily have to have the proteinuria anymore to make the preeclampsia diagnosis. So sometimes we'll be making this diagnosis now if there's a sudden worsening in blood pressures or difficulty controlling blood pressures on a more complex regimen of medications later in pregnancy. For women who have nephrotic syndrome and hypertension, this can be a very difficult diagnosis to make as well. But again, we're typically looking at a fairly sudden change in clinical situation or a sudden increase in protein, blood pressure, or other laboratory findings. HELP syndrome is the last in this family of hypertensive disorders. HELP is an acronym. It stands for hemolysis, elevated liver function tests, and low platelets. The typical symptoms are right upper quadrant pain, which is seen in about 80% of women, although some women don't complain of right upper quadrant pain. Rather, they complain of some new onset nausea, some new onset epigastric discomfort. Some of our inpatients think that maybe they ate some bad food from the cafeteria. Typically, that ends up being HELLP syndrome. Women with HELLP syndrome may describe a rapid increase in weight gain or edema, or they may be asymptomatic. Some women with HELLP syndrome don't have all of the criteria, so they may have low platelets and elevated liver function tests without hemolysis, but often still will carry the diagnosis of HELLP syndrome. Platelets can drop rapidly, which can complicate pregnancy. HELLP syndrome is also associated with a relatively high risk of seizure or eclampsia, so another circumstance in which we would give prophylactic magnesium until the time of delivery and for 12 to 24 hours post-delivery. Pregnancy is often referred to as a window to future health. Pregnancy may reveal to women their underlying predilection towards lifelong diseases such as cardiovascular disease. So those women who develop preeclampsia and or gestational hypertension should be aware that they have some significantly increased risk of lifelong development of cardiovascular disease. There is a gradation in risk by the severity of their pregnancy-related disease, such that women with mild hypertensive disorders of pregnancy have a relative risk of 2, whereas those with more severe disease may have a relative risk as high as 5 of developing cardiovascular disease. Lifestyle interventions certainly may be helpful. So let's move on then to diabetes in pregnancy, another of the most common complications that we see during pregnancy. Diabetes can be divided into diabetes of onset prior to pregnancy and during pregnancy. Onset prior to pregnancy is referred to as pregestational diabetes, and this would encompass type 1 diabetes, type 2 diabetes, and also to some extent those women who have glucose intolerance on first trimester screening without a clear diagnosis of type 2 diabetes. Pregestational diabetes complicates about 2% of all pregnancies, although this prevalence is increasing. As you see, it was only 0.8% in 1999, and that is, of course, due to some of the other characteristics of our population as a whole. Gestational diabetes has been recognized since the early 1800s. There was the first documented case report back in 1824 of a woman with hyperglycemia and stillbirth of a macrosomic infant at 22 weeks. The term gestational diabetes, though, didn't come into vogue until approximately 1980. And essentially, this is a disorder, again, related to the placenta. So placental hormone function results in carbohydrate intolerance. And some gestational diabetes is treated with dietary changes, some with insulin, and a smaller percentage with oral medications. Gestational diabetes is thought to complicate approximately 7% of pregnancies, but this depends largely on what screening tool physicians are using to make the diagnosis. There's a lot of controversy around diagnosis of gestational diabetes in pregnancy. Everyone agrees that we should be screening women between 24 to 28 weeks gestation. They just don't agree on how. So the American College of Obstetricians and Gynecologists endorses a 2-step process for diagnosis of diabetes, in which 6 to 7% of pregnant patients will be diagnosed with gestational diabetes. The ADA and IADPSG endorse a 1-step process. Unfortunately, with this screening tool, up to 20% of all pregnant women will be diagnosed with gestational diabetes. The NIH consensus recommended that we continue with the 2-step process. So the 2-step process is an initial screen with a 50-gram glucose load with a 1 hour after blood test. Abnormal values are either 130 or 140, depending on the type of diagnostic criteria that the center is using. For women who have an elevated value, they then move on to a 100-gram 3-hour glucose tolerance test, again, with 2 different classification criteria. For the sake of interest, the one-step screening process is actually a 75-gram glucose load. So you may have heard this terminology for diabetes classification in pregnancy. This is called the White criteria. And it's not used very frequently anymore outside of type A1 and type A2 diabetes, which continue to be used a little bit more frequently. So A1 and A2 diabetes are both gestational diabetes. Type A1 diabetes is diet-controlled diabetes, and type A2 is medication-controlled diabetes. This classification is specific to obstetrics. So overall principles of treatment for diabetes include daily self-monitoring with typically nutrition counseling, aiming for optimal carbohydrate balanced meals. The best therapy for hyperglycemia in pregnancy remains to be insulin. Insulin has best outcomes for moms and babies. Oral hypoglycemics are used in some places, but in general are inferior to insulin as a medication treatment. Again, thinking about pregnancy as a window to future health, women with gestational diabetes carry a 50% risk of developing type 2 diabetes later in life. The goal is for women to have a 75-gram glucose tolerance test at their 6-week postpartum visit in order to screen them for underlying type 2 diabetes. Otherwise, they should continue with their primary care doctor to have annual diabetes screening. So let's move then to select maternal hematologic conditions. So we'll speak briefly about inherited versus acquired thrombophilias. So inherited thrombophilias are those like factor V Leiden, prothrombin gene mutation, antithrombin deficiency, protein S and protein C deficiency, which increase risk of blood clots. There can be some confusion when looking at pregnant women as to who carries the risk. So pregnancy is a time of increased risk of blood clots, partly mediated by estrogen-related changes. Women who carry inherited thrombophilias are at increased risk of having a blood clot during pregnancy, and some relatively clear guidelines for pharmacologic prophylaxis exist. Typically, for those women with a high-risk disorder or a strong family or personal history, they will have therapy with either low molecular weight heparin or heparin to reduce the risk of blood clot. Now, what's important to recognize, though, is that the risk really is just to mothers. There's minimal fetal risk when it comes to inherited thrombophilias. That's different from acquired thrombophilias. So antiphospholipid syndrome is a syndrome of acquired thrombophilia, which is characterized by laboratory criteria of abnormal blood tests and clinical criteria, which can either be a clot or some specific obstetric criteria. So for women to have the diagnosis of antiphospholipid syndrome, they have to have persistently abnormally elevated antiphospholipid antibody blood tests. Those include anticardiolipin, IgG and IgM, lupus anticoagulant, and beta-2 glycoprotein. These need to be elevated on at least 2 occasions 12 weeks apart. The clinical criteria, as I said, could either be a vascular thrombosis or it can be pregnancy morbidity. That pregnancy morbidity can be 1 or more unexplained deaths beyond 10 weeks gestation. It can be 3 or more unexplained spontaneous abortions prior to 10 weeks gestation, or the premature birth or death of a neonate before 34 weeks gestation due to hypertensive disorders of pregnancy or clear uteroplacental insufficiency. And that is, again, because unlike the inherited thrombophilias, the acquired thrombophilias can actually impact the fetal outcome. So women with antiphospholipid syndrome are treated with low molecular weight heparin throughout the pregnancy. Women who carry antiphospholipid antibodies but don't have antiphospholipid syndrome will just have aspirin, low-dose aspirin over the course of pregnancy. Okay, looking at platelet disorders. So, the most common change in platelet counts is going to be related to gestational thrombocytopenia, or in other words, low platelets at pregnancy. Typically, this thrombocytopenia is mild. As I mentioned before, normal platelet counts in pregnancy are over 150,000. Platelet counts in women with gestational thrombocytopenia tend to be over 70 or 80,000, and therefore not precluding regional anesthesia at the time of delivery. Most of these women have resolution of their platelet counts in the postpartum period and have no neonatal consequences related to their thrombocytopenia. For women who have lower platelet counts, we do need to be more concerned about conditions such as ITP, which can be associated with neonatal thrombocytopenia as well. A few words on breastfeeding. Uh, Breastfeeding carries a lot of benefits both to babies and to mothers, and unfortunately, complications during the postpartum period that require, for example, diagnostic imaging or surgical procedures can be very disruptive to mom's breastfeeding success. Moms are often advised to pump and dump their milk, or they have long imaging studies or procedures that may interfere in their scheduled pumping. And I just want to go over a couple of the medical benefits to reinforce just how important breastfeeding success is. So, breastfeeding has been demonstrated to decrease infants' likelihood of infections. It's also been demonstrated to improve babies' lifelong risk of cardiovascular disease, diabetes, and some cancers. Looking at moms, this is one of several studies that has demonstrated an improvement in cardiovascular risk in mothers who breastfeed. So this is a study of 89,000 women from the Nurses' Health Study, showing that compared to women who were never pregnant, women who breastfed for only 3 months had a reduced lifelong risk of cardiovascular disease. And the longer that you breastfeed, the greater the reduction in cardiovascular disease is. Similarly, breastfeeding is protective from development of type 2 diabetes in mothers as well as in their children, independent of physical activity and independent of BMI later in life. There are many, many, many medications that are compatible with breastfeeding, including many anesthetics and including contrasts. So women are still being advised to pump and dump after they have contrast studies. This is no longer recommended. If you have any hesitation or questions about what medications are compatible with breastfeeding, you can refer to the NIH website of LactMed, which gives the most up-to-date and useful information on safety of medications during breastfeeding. Okay, so let's close by talking about a few common surgical conditions in pregnancy and some basic principles around surgery in pregnancy. In 2017, the American College of Obstetricians and Gynecologists, along with the American Society of Anesthesiologists, released a new committee opinion regarding the safety of surgery in pregnancy. And the basic tenets are the following. First, a pregnant woman should never be denied indicated surgery, regardless of what trimester she is in. Elective surgery should be postponed until after delivery. And if possible, non-urgent surgery should be performed in the second trimester when preterm contractions and spontaneous abortion are least likely. I will mention as a caveat here, this is not because we think that surgery causes miscarriage in the first trimester, but rather miscarriage in the first trimester is very, very common. Unfortunately, if a woman has a procedure and then subsequently has a miscarriage, the question of causality will be raised. The obstetric complications are much less common in the second trimester, so it tends to be a relatively safe time to perform surgery. Additionally, there is much less complexity as the fetus is previable. So we can divide recommendations for surgical management into prior to fetal viability and post viability. Fetal viability is defined slightly differently at every center. In general, the current thinking is that viability is beginning from approximately 23 weeks gestation. For a pre-viable fetus, The only fetal monitoring that is necessary is a fetal heart rate check prior to and immediately following the procedure. Post-viability, things become a little bit more complicated. In some circumstances, electronic fetal heart rate monitoring may be appropriate. It's only appropriate if it's feasible. So some surgical positioning will not allow placement of electronic fetal monitors. The electronic fetal monitor is just basically a round disc about 3 centimeters in diameter, which is attached by a belt around the woman's belly. Continuous fetal monitoring should only be performed if there's a provider who is willing and able to intervene for fetal indications during the surgery. If the patient has provided informed consent for an emergency delivery, if it's possible for her to provide consent, and if the nature of the procedure would allow safe interruption for delivery. Electronic fetal heart rate monitoring can also be used as an additional vital sign. It may help in terms of understanding if the patient's positioning or if her blood pressure are adequate for placental perfusion. We can see drops in the fetal heart rate when blood pressure goes too low, or if there is too much compression of the inferior vena cava. Surgery post-viability should be performed at an institution that has neonatal services. There should be an obstetric care provider with cesarean delivery privileges readily available during the surgical procedure. And there should be a qualified individual readily available to interpret the fetal heart rate on the monitor. Surgical procedures can be performed both laparoscopic and open. Laparoscopy can be performed very safely in pregnant women, and in many centers is the preferred modality. Optimally, these procedures will be performed in the second trimester. However, there are descriptions of procedures even as late as 34 weeks gestation. There are some general guidelines about laparoscopy, some of which also are relevant to open procedures, including use of pneumatic compression boots. Of course, as I mentioned, pregnant women are at increased risk of developing DVTs, so boots should be used as a minimum. Pharmacologic prophylaxis should be used for higher risk patients or for longer procedures. Typically, if the procedure allows it, we recommend a left lateral tilt or a uterine displacement to decrease compression of the inferior vena cava. There is grade 2C evidence that suggests maintaining intra-abdominal pressure at less than 15 millimeters of mercury to avoid a decrease in placental blood flow. And similarly, grade 2C recommendations to keep end-tidal CO2 at 32 to 34 milligrams per mercury as respiratory acidosis becomes unlikely at this level. So a few words on gallstones and appendicitis. Unfortunately, the hormonal changes of pregnancy may promote gallstone formation. However, overall, the incidence of gallstone-related disease in pregnancy remains quite low at less than 1%. The majority of these women can be managed with conservative measures, but some will, of course, need surgery. As you're making your differential for right upper quadrant pain, remember that there are some specific pregnancy-related conditions which may also cause right upper quadrant pain. One of these is HELP syndrome, which we reviewed, acute fatty liver, which is another obstetric emergency. A classic sign of acute fatty liver is significant hypoglycemia. The other conditions that can be associated with right upper quadrant pain are more typically associated with generalized abdominal pain or lower abdominal pain, but it's worthwhile remembering the placenta. Placental abruption can cause quite significant pain. Uterine rupture and intraamniotic infection also can cause some significant pain, although not classically in the right upper quadrant. When you think that surgery might be indicated, you don't need to hesitate. Really, surgical treatment is associated with lower complication rates than non-operative management, 4% versus almost 17%. And similarly, there is also a decrease in fetal complications in mothers who were treated with surgery as opposed to non-operative management. Surgical management is not associated with increased risks of preterm delivery or preterm birth. For women who have a lot of cramping associated with procedures, there is a potential role for giving a medication like indomethacin as long as it is prior to approximately 30 weeks gestation. And rarely we might give steroids for fetal lung maturity prior to surgery. if we're worried about a viable pregnancy. But these specific recommendations can be discussed with a local obstetrician prior to performing the surgery. What about appendicitis? So thankfully, the risk of appendicitis does not increase in pregnancy. The incidence is approximately 0.1%. And while appendicitis may present with very classic symptoms, sometimes the diagnosis can be a little bit more tricky. Remember again that maternal white blood cell count increases during pregnancy, potentially as high as 16, maybe even 18. But a left shift is not normal. So a woman presenting with fever, left shift, and pain is more likely to have appendicitis. The classic diagnosis using pain at McBurney's point also needs to be considered. Intra-abdominal shifts of organs may lead to the pain being somewhere near McBurney's point, but not exactly there. Rebound and guarding have been described to be somewhat different in third trimester patients, although, again, often the rebound and guarding are also seen along with pain quite near McBurney's point. Right, lower quadrant pain also carries a differential diagnosis with some very specific pregnancy-related conditions, such as ectopic pregnancy. Postpartum patients carry a risk of ovarian vein thrombosis, particularly in those women who were delivered by cesarean rather than by vaginal birth. Many times, women with presumed appendicitis are imaged prior to the decision being made for either medical or surgical treatment. Indicated imaging should be performed when necessary. Optimally, that imaging will be either ultrasound or MRI, both of which carry an excellent safety profile in pregnancy. However, there are some centers in which a CT with contrast is going to be the best study to evaluate a patient with concern for appendicitis. Many have concerns about exposing pregnant women to abdominal CTs with contrast. However, the radiation exposure from an abdominal CT is well within the range considered to be acceptable for pregnancy and for fetuses. So, in other words, a pregnant woman with appendicitis should be evaluated as though she isn't pregnant, with a preference for ultrasound and MRI imaging. Every baby is going to do better if mom doesn't have a ruptured appendix or become septic from her appendicitis. So surgical management and imaging are all appropriate.